but also health administrators and economists, because the burden involved is simply too immense. As a case in point, let me just present information that I had compiled for a recent talk for the Southern Chapter Indian Society of Nephrology on the increasing demand for dialysis in just our district. Shown in dark stars here are dialysis centers in hospitals with full-time nephrology support. In light pale stars are dialysis centers in hospitals without full-time nephrology support, and these dark circles are standalone dialysis centers. Compared to the year 2004, in the year 2015, early 2015, we see a significant increase in the number of dialysis centers, and I'm just talking about one district in our whole country. Nationwide, we know that the prevalence of ESRD is increasing. It's right now 400 per million population, pegging the total number of ESRD patients at close to 500,000. Only a minority of whom are actually treated, about 12%, with very little nephrology support and other infrastructure. And this high ESRD annual growth rate of about 7% is driven largely by diabetes and hypertension. The epidemiology of diabetes presents an alarming picture. We know that for the year 2030, the projected diabetes population is going to expand to 80 million. And Kerala state has rightly earned the rather unsavory tag of being the diabetes capital of our country. We have data from Trivandrum, and this is the study conducted by my mentor, among others, Dr. Pishardi, which has pegged the prevalence of diabetes mellitus in Trivandrum at 16.3%, and a later study from Ernakulam puts the prevalence at around 20%. So a veritable explosion in diabetes was waiting to happen. And at any point in time, we know that the prevalence of impaired GFR in diabetic populations varies between 15 to 22%. I apologize for this crowded slide. This was taken from a recent article in WJD. Just wanted to highlight the demand study published in 2006 in KI, large study of more than 32,000 patients, in whom 11,000 patients decreased GFR data was available and was pegged at 22%. We know that diabetes has a tendency to involve many different areas in the kidney. We know of the arteriolar hyalinosis. We know of the earliest stage, the GBM thickening. We know of the mesangial cell proliferation and the collagen deposition leading on to the classic KW lesions in diabetes. And we also know about podocyte loss, food process effacement, and the tubular epithelial atrophy that can happen in diabetes. We are also aware of the profound microcellular changes that can happen in diabetes. We know of the renin-angiotensin-aldosterone axis mechanisms resulting in intraglomerular pressure, increased intraglomerular pressure. We also know about the PKC pathway, the advanced glycation end products, the intracellular reactive oxygen species, and the polyol pathways, all of which finally lead on to tubulointerstitial fibrosis, mesangial matrix expansion, and finally lead on to the syndrome of decreased GFR and increased proteinuria, which marks diabetic nephropathy. A natural progression of diabetes would mean an initial phase where there is some degree of hyperfiltration going on to proteinuria and an eventual decrease in GFR. And we also know of the term microalbuminuria, which has been interpreted and has caused considerable degree of confusion and is fooling the best of us. We know we constantly have to educate our junior colleagues, our patients, that microalbumin is not a special type of albumin, it's just albumin excreted in small quantities. And when I say it keeps fooling the best of us, this is a graphic which I have taken from the latest edition of Harrison, which has mislabeled more than 300 milligrams of per 24 hours of protein as actually microalbuminuria. So that snippet aside, we know that there is now a changing terminology. What was formerly called microalbuminuria, we now call it a moderately increased albuminuria to eliminate some of the confusion involved. And what was called the macroalbuminuria, we now call severely increased albuminuria. But for today's discussion, I would stick to micro and macro because, for one, it is easier on the tongue, and two, these are two terminologies that are very familiar to all of us. More than terminology, we should also appreciate that there is a changing significance in the role attributed to albumin excretion in terms of progression of diabetic nephropathy. Traditionally, microalbuminuria has been considered to be a marker of early nephropathy or incipient nephropathy, and it's also considered to be a risk factor for macro and microvascular disease. But one has to remember that there are a large number of individuals with diabetes who may never manifest albuminuria, and some studies have shown to be as high as 50%. And a mere presence of microalbuminuria does not translate into diabetic kidney disease because microalbuminuria is known to remit. Microalbuminuria becomes significant only when it progresses to overt proteinuria and eventually to decreased GFR. And when we talk about decline in GFR, an age-related eGFR decline of about 0.75 to 1 mil per minute, normalized to 1.73 meters square per year, is expected in any individual more than 40 years of age, whereas this rate of decline becomes more prominent in men and women with diabetes. But a natural history of a GFR decline does not follow one path. There could be a number of diabetic patients who follow the path marked D, where they begin with normal filtration and end with normal filtration. A small number of patients might actually hyperfiltrate but then remain in the range of normal filtration. We are more worried about the paths A and B, where in one there is a decline from normal filtration to hypo, and in the second there is an increase to a stage where there is hyperfiltration and eventually going down to hypofiltration. So our targets are to make interruptions in these and prevent progression to a stage where people would eventually need dialysis or other forms of renal support. So then it becomes important for us to revisit what are the initiators and promoters of diabetic kidney disease. We all know that hyperglycemia is the number one in both categories. We know of predisposing genes and a number of other risk factors which promote diabetic kidney disease. And some of these I would like to call unmodifiables. Ethnicity we cannot modify. South Asian descent, Hispanic descent, blacks nowadays are all at greater risk of progression. There have been studies, especially conducted from UK, which have shown that South Asians have a lesser tendency to go on to the stage of microalbuminuria initially during the course of diabetes, and would rather go fast into a stage of overt proteinuria and diabetic kidney disease, or overt proteinuria and decreased GFR, I should say. Demographics, age and male sex predispose people to diabetic nephropathy and progression, and these are not modifiable. Duration of diabetes, again, is not modifiable, and there are a number of genetic risk factors. A large number of candidate genes have been implicated in diabetic kidney disease progression. Of these, the I and I/D, insertion deletion polymorphisms and DD polymorphisms of the angiotensin converting enzyme gene have been studied the most. And it has been found that the strength of association of these polymorphisms are the best with type 2 diabetes and not with type 1. And again, the strength of association is more for South Asians than for other racial and ethnic groups. So coming on to the modifiables, and this is something that all of us know and constantly practice in our day-to-day clinical life. What are the modifiables? Glycemic control, VAS inhibition, BP control, and others. In this segment of others, there are a number of factors like weight reduction or lipid control or diet protein restriction, which can help in preventing progression of chronic kidney disease as a whole, and not specifically to diabetic kidney disease. But in today's talk, I will speak about a number of newer therapeutic targets which have shown some promise and some promises which have been belied. So, but going on to the point of glycemic control, any discussion on glycemic control in type 2 diabetes will have to start with the UKPDS. And I'm sorry to be projecting this graphic in front of so many of my teachers and learned colleagues, because we all have seen this graphic n number of times. We know that in the UKPDS study, more than 4,000 patients were randomized to a conventional glycemic control regime versus a more intensive regime, and a difference of HbA1c of 7.9 versus 7 was achieved, and a 25% reduction in microvascular endpoints was achieved with the more intensive glycemic control, thereby setting an HbA1c of 7 as the benchmark for glycemic control in diabetes, in type 2 diabetes, and also type 1 diabetes. The long-term data of UKPDS was published several years back, which shows an amazing legacy effect, which again shows us that despite that early loss, despite the loss of that early benefit in terms of glycemic control between groups, the benefit in terms of microvascular disease reduction persisted over many years. Again, emphasizing that glycemic control has a significant role in terms of preventing progression of diabetic kidney disease. The advanced study was published again a few years back. This was to look at a slightly lower target of HbA1c, a large multi-center study looking at an HbA1c target of 6.5, and they found that in the combined major macro and microvascular endpoint, there was a benefit for an HbA1c target of 6.5, and this was largely driven by the benefit in terms of nephropathy. So the advanced studies seem to indicate that if you bring down HbA1c to 6.5 as opposed to 7 in UKPDS, there seemed to be a benefit in terms of nephropathy prevention. The long-term results of the advanced study was published last year, again showing a benefit for ESRD, end-stage renal disease prevention, in terms of tight glycemic control to a target of 6.5. But what has to be remembered is the actual event rates were so low in, sorry, can I get another pointer, please? The actual event rates were so low that they had to put a separate insert for this graphic to actually show that there is a difference between the two groups in terms of glycemic control. Simultaneously, the ACCORD study was published, which was actually looking at a greater, lower target of HbA1c to 6. And this is a predominantly North American study which had to be abandoned midway because there was an increased risk in cardiovascular and all-cause mortality when they attempted a target of HbA1c of 6. Okay. HbA1c of 6. And long-term data of the ACCORD study, sorry, I should say a reanalysis of the ACCORD study, looking at about 3,000 of the original patient cohort with chronic kidney disease, again showed that all-cause mortality was 31% higher and cardiovascular mortality was 41% higher when one attempted to target an HbA1c of 6 in this particular patient population. So where do we stand in terms of glycemic control in 2015? We know that there is an improvement in microvascular complications, but one has to balance that against the U-shaped association of mortality with HbA1c. And it's reasonable now to say that one should target an A1c of less than 7, perhaps higher in older and frail individuals. And I know that most of the guidelines would make this recommendation. RAS inhibition. What is the role of renin-angiotensin-aldosterone axis inhibition in diabetic patients who are hypertensive, who do not have renal involvement? 4 trials. The one marked in red is the only negative trial. Both the Benedict and Advanced trial looked at ACE inhibitors. Roadmap looked at olmesartan. All of these trials showed an improvement for microalbuminuria. Please remember that the Roadmap study, in the Roadmap study, olmesartan was flagged to be showing an increased cardiovascular mortality. And a similar picture was also seen in the Orient study involving olmesartan. So, as you all know, olmesartan is now being investigated by FDA in terms of why there was this increased cardiac mortality with olmesartan use. The two trials that have changed nephrology practice in a big way were IDNT, and the next one was Renal, both published in 2001, both of which looked at the role of angiotensin receptor blockers in people with established chronic kidney disease. In IDNT, the mean serum creatinine was 1.7. In Renal, it was 1.9. And in IDNT, it was shown that in terms of a combined endpoint of doubling of creatinine, end-stage renal disease, and mortality, irbesartan performed significantly better compared to amlodipine or placebo. A similar picture was seen with losartan in the Renal study, significant improvement in a combined endpoint of both end-stage renal disease and doubling of serum creatinine in this particular study. So, based on these two trials and several other smaller studies, the role of ARB has been accepted to be one of a standard of care for the management of diabetic nephropathy, especially in terms of prevention of progression of chronic kidney disease. So where do we stand, however, in terms of combination of agents in renin-angiotensin-aldosterone inhibition? What is the role for combining ARB and ACE? Back during my training days, it was a big thing to be combining an ARB and an ACE inhibitor in an effort to prevent progression of kidney disease. Is there any role in combining an ACE-ARB with a direct renin inhibitor? How about combining it with an aldosterone blocker? The VA Nephron study was published 2 years back, which has shown that a combination of losartan and lisinopril does not really improve outcomes compared to either agent, but actually worsens the side effect profile in terms of hyperkalemia and acute kidney injury. And as many of you know, this study was withdrawn midway because of this adverse effect profile. The Altitude study, again, looked at combining aliskiren, the direct renin inhibitor, with a baseline of either ACE or ARB. And again, this study was withdrawn because there was a higher risk of hyperkalemia, hypotension, and diarrhea. And the main reason why most patients went on to a study drug discontinuation was in fact hyperkalemia. So now, based on these two very large studies, it is very difficult for anyone to make a recommendation to combine an angiotensin receptor blocker with an ACE inhibitor or a direct renin inhibitor with a more traditional ARB or ACE inhibitor. What about the role of aldosterone antagonism? We really have no long-term data on the GFR benefit in combining an aldosterone blocker and an ACE inhibitor or an ARB. There are some very small studies which show proteinuria improvement, but there is a definite risk of hyperkalemia. Many years back, when the RAL study came out for the CHF benefit in terms of spironolactone, and spironolactone was used, became more prevalent in use, a subsequent study was done in Canada, in Ontario, looking at the prevalence of hyperkalemia in these treated patients, and actually found that a general practice picking up hyperkalemia was more prevalent post-RALS era than pre, meaning to say that an unrecognized hyperkalemia epidemic goes on when one uses spironolactone or other aldosterone antagonists more and more. So where do we stand in 2015? ARB remains the mainstay for prevention of progression. Dual blockade has been found to be harmful in studies. Combining aldosterone antagonists with ARB ACE inhibition may be tried, but cannot be deemed the standard of care as of now. What about BP control? Again, going back to the UKPDS, we know that for every 10 mm decrease in systolic blood pressure, a 12% decrease in mortality was found in the UKPDS cohort. And this benefit extended right up to systolic BP of less than 120. And that's the reason why traditionally most of our guidelines would want diabetic patients to have a lower blood pressure threshold than other patients. But in the ACCORD patient population, a BP trial was also conducted. 4,733 patients randomized to either an intensive BP control or more standard control of BP. There was no significant difference in outcomes, but there was a significant increase in adverse effects in the intensive group. And based on this study, and the JNC 8 recommendation specifically mentions the ACCORD study, based on this study, most major guidelines would now say that the blood pressure goal in patients with diabetes mellitus should be less than 140/90, although, as we know, prior guidelines had suggested a more intensive lowering to less than 130/80. What about the others? A number of molecules have been looked at as newer targets for prevention of progression in diabetic nephropathy, starting with pirfenidone, which is a TGF-beta inhibitor, bradoxolone, I'll come to it in subsequent slide, pentoxifylline, our good old Trentol, the Sentans, which are all endothelin antagonists, and lastly, ruboxostaurin, which inhibits protein kinase C. I will briefly review the evidence, the best evidence in pertaining to the ones marked here, and will not talk about ruboxostaurin today. Just to briefly mention, the PKC inhibitor was investigated in small trials, small number of patients, and found to have a small benefit in terms of proteinuria reduction, but no significant reduction benefit in terms of GFR progression. Pirfenidone, as we know, has been approved for use in idiopathic pulmonary fibrosis. This was a very small trial published in JASN 4 years back. A total of only 77 patients randomized into 3 groups, placebo and 2 doses of pirfenidone. And what they found was that the 1200 milligram dose of pirfenidone was found to have benefit in terms of change in GFR. But there are a number of red flags in this trial. Of the 77 patients who were initially randomized, only 55 actually completed the study. Patients in both groups of pirfenidone, a number of patients withdrew from the trial, citing adverse effects. And also, the small number itself prevents us from going into any terms of any kind of meaningful understanding of the benefit of pirfenidone in prevention of progression of DKD. But this is the only trial that is available in terms of TGF-beta prevention. Avosentan was looked at in a trial which was published several years back. Again, a study of about 230 patients. Compared to placebo, various doses of avosentan were found to have a benefit in terms of urine albumin excretion. There is actually a larger trial based on atrasentan going on at this time. It is called the SONA trial, and the result is awaited in 2018. And because, again, this is a small trial and endpoints are kind of soft, we cannot, at this time, make any strong recommendations about endothelin receptor antagonists. The Beacon trial based on bardoxolone. Bardoxolone is a transcription factor stimulator. The NRF2 transcription factor is found to be depressed in situations of inflammation, and the thought was that when that transcription factor is stimulated, perhaps inflammation and progression of kidney disease could be avoided. This was an industry-sponsored trial, large trial involving more than 2,000 patients, and again, this study had to be withdrawn midway because there was an increased risk of cardiovascular side effects with bardoxolone than compared to the placebo group. Again, there was no significant difference in endpoints between bardoxolone and the placebo. And this is the latest that we have, published just in January this year in JASN. Good old pentoxifylline is making a comeback in diabetic kidney disease. This is a study which randomized about 80 patients in each group, diabetic kidney disease patients in stage 3 and 4 chronic kidney disease, randomized to 1200 milligrams of Trentol compared to placebo on top of RAS inhibition. And they found that there was a decrease in urine albumin excretion with pentoxifylline and a lesser decrease in GFR decline, perhaps showing that pentoxifylline has some promise. But then again, it's a small trial, the endpoints are soft, we need larger trials with better data to come to any kind of conclusion. So where are we in terms of newer molecules? Clearly, we need more data. And as I was saying, pentoxifylline seems promising. So where do we stand in 2015? We know that the glycemic control target should aim for an A1C of less than 7. We have seen that BP control should be to a target of less than 140/90. And currently, RAS inhibition with a single agent seems to be the go-to guy in terms of renoprotection in diabetic kidney disease. And this big question mark remains as to where the next big push will come in terms of preventing adverse outcomes in our patients with type 2 diabetes. And when Dr. SK wanted me to talk about this, he wanted me to go beyond RAS inhibition. But unfortunately, our cupboard is quite bare at this time. And I can only say that the more things change, the more they stay the same at this time. Perhaps the future will bring us a different story. Thank you very much.
Thank you, Dr. for that wonderful presentation. See, of late, DPP4 inhibitor has this anti-fibrotic effect, and it can prevent it. There's a study going on there. Can I hear that?
The gut renal axis is coming up big in literature in terms of CKD progression. But I was trying to present data that would actually strongly support that contention. Many years back, when PPAR gamma agonists came into play, and there was a thought that because there was mesangial representation of PPAR gamma, perhaps thiazolidinediones would make a difference. But that hope was belied later. So I would like to see some solid evidence from literature before this hypothesis, before I would consider this hypothesis to be proven. But yes, there is a hypothesis in terms of incretin mimetics as a strategy for prevention of progression of CKD in diabetes.
Maybe I'll put this to the forum. Anybody has questions on this? What is it?
Thank you, Dr. Jyothish, for the nice talk.
Thanks.
It's pretty stressing the importance of renoprotection in diabetes. Actually, the diabetes main problem is to get the glycemic control adequately. Because you have to educate a patient that they should get a good glycemic control if they want to protect their kidneys. Most of the patients, after a few years, they are at least bothered about the diabetes status. The blood sugar is 300, 400, they just go on continuous model medicine, and they don't bother to regular monitoring also. So that's the main problem here, why we are getting a marked increase in the number of renal failure patients with diabetes. Because the patients, you don't take it seriously at all. Even if the doctors trust, they still don't take it seriously. Doctors often, the patient comes to the doctor with a A1C, they add one more drug. Patient goes back, after several months he comes back again with another A1C report. One more drug is added. Like that, lot of polypharmacy here. Rather than trying to get a good glycemic control with the insulin or the necessary drugs as required. But protection is often spelled because BP patients are often they are conscious, they are aware of that. Nowadays there are a lot of patients buying the electronic BP apparatus also, and they do check at home also. Often they are after the glycemic control, but blood sugar they are released to that. But sometimes it's difficult to get a good glycemic control also another way. When they have renal damage or renal failure, often it's very difficult to get a good glycemic control. Whatever the regime you are using, when the basal bolus regime, often you don't get a good glycemic control as we expect to get a better prevent the diabetic kidney progression.
Is there any role for statins
Very good question. Statins have a role in terms of cardiovascular risk prevention in not just diabetic nephropathy, but also other chronic, other categories of chronic kidney disease. But statins have never been shown in scientific literature to actually prevent progression of diabetic nephropathy. But that does not prevent us from prescribing statins to our patients. So to answer your question, is there scientific evidence to prove that statins prevent progression of diabetic kidney disease? I'll have to say no. But then it's standard of care, it's good medical practice to be prescribing statins. Another point that I would want to add is in patients with diabetic nephropathy already on dialysis, there is no real benefit to adding statins after they are on dialysis. There have been a number of studies looking at this and finding no increased benefit in adding statins. One does not necessarily need to withdraw statins when someone goes on dialysis, but to start the statins afresh when for various cardiovascular indications after they have been on dialysis does not make sense.
Sir, can you add on to it?
Nice talk. Is there any role for silly people they are advocating whether anti-proteinuric care compared to
the scientific answer is there's nothing that is proven in literature to show that cilnidipine works better than anything else. If at all one would want to use a calcium channel blocker, it should be a non-dihydropyridine calcium channel blocker like diltiazem or verapamil. There is absolutely no evidence to say that cilnidipine works, although industry would like us to believe differently. I have been guilty of using cilnidipine, but lately I've decided to switch to a more conventional dihydropyridine calcium channel blocker like amlodipine in terms of both cost and perhaps equivalent blood pressure control. So to answer your question, sir, I don't know. I don't think there is any evidence to back the contention that cilnidipine is superior in terms of other calcium channel blockers, dihydropyridine calcium channel blockers for proteinuria prevention. No.
Before we come with the SEARB combination therapy, there was many studies saying that it is useful. Previously, so evidence was more in favor of combination therapy. I'm sure you also would have been having some patients with this combination with macroproteinuria. What are you going to do with those patients now? Because you also have some patients.
Right. Till the VA nephron study came in, sorry to interrupt you there, but as you know, in the history of combination therapy for ACE and ARB, in the non-diabetic nephropathy group, we know of the infamous corporate study, which was withdrawn because of evidence for malpractice, and that was a completely fabricated study coming in from Japan, the corporate study. And in terms of the on-target study, which combined telmisartan and from the HOPE group, there was no benefit and there was a suspicion of harm. But then we thought that perhaps in a proteinuric category of patients, there would still be benefit in combining the two. So for the longest time, even after the on-target study came in, I kept continuing my old patients on both an ACE and ARB on the same prescription. But with the VA nephron study now coming in, it becomes extremely difficult. But I must admit that there is a very small subset of my patients who are still on dual blockade, whom I'm very diligently following the potassium. It's basically the hyperkalemia and the hypotension and the acute kidney injury that worries us. If someone is pristinely controlled and does not have any problems whatsoever on a combination, I don't see a rationale just on the basis of a study like this to be withdrawing them from what works for that particular patient. But having said that, I would be very hesitant to start someone new on a combination of ACE and ARB.
Anybody else?
any biomarkers to predict the renal normal prior to the microalbuminuria?
As you know, in acute kidney injury literature, there seems to be a number of molecules, including the NGAL and a lot of other molecules. Some of these molecules have been investigated for diabetic nephropathy as well. But as is the case in acute kidney injury, these biomarkers have not really fulfilled their promise in diabetic nephropathy. Again, in 2015, if I am asked to suggest one biomarker which will predict diabetic nephropathy before microalbuminuria, the answer is there is none. Perhaps in the years to come, something else will come up, but there's nothing right now.
Until what level of creatinine will you use this and beyond that what?
Thank you very much for asking me that question, sir, because it is a common misconception that one should not be using RAS inhibition beyond a certain level of GFR. When I was initially trained, the magic number that was given to me was 4 milligram per deciliter. You cannot use ACE-IRB beyond 4 milligram per deciliter of creatinine. But there have been trials, including a very important trial called RAIN, which was published from Europe, which looked at the use of ramipril in various sets of GFR and found the best benefit for ramipril in GFR less than 15. So based on that study and based on the fact that there are a number of extrarenal benefits for using RAS inhibition, there is no level of GFR below which I will not start ARB. But the caveat being, I will have to monitor these patients who are closer towards dialysis more closely for a GFR worsening or a complication of RAS inhibition like hyperkalemia. If I'm able to do that, if I'm sure that the patient is going to come back to me for follow-up, then I would start RAS inhibition for any level of GFR. I would not automatically discontinue RAS inhibition just because creatinine is at a particular level. Having said that, the important thing to remember is one should only allow a 30% increase in creatinine after ARB has been started or ACE has been started. Now, if the rise of creatinine is more than that particular 30%, then immediately ask people to stop. In fact, this is the only situation where I actually give my phone number out to my patient. When I ask them, when I start an ARB and I expect creatinine to rise, I ask them to repeat the creatinine potassium after 3 or 4 days and give me a call back. The moment it goes beyond that, and I ask them to stop it immediately. But having said that, I have not had to do that not once in the past 2 years after coming to Calicut. No.
Is 13% over a period of?
In the immediate period. Gradually, GFR can worsen. Okay, but I'm saying you start ARB or ACE and a 30% rise happens over a period of days, then clearly you're looking into.
And is there any drug beyond that? If it goes beyond 30%?
I didn't get the question, sir. Then the other thing that I usually do is a non-dihydropyridine calcium channel blocker like diltiazem, because that has shown to be of some benefit. But having said that, there are also studies which have shown that diltiazem works best in combination with RAS inhibition, and perhaps not much as a standalone. So if you're really compelled and if you have no other options, then we may have to just tell our patients that there are no other options.
Thank you, Doctor, for the presentation.
Thanks.
I invite the Dr. to hand over. The next is we have some interesting